Hello and welcome. My name is Michael Lavico, and today's presentation is on secondary causes of osteoporosis. Now, I wasn't going to go through and do this whole thing myself, but as luck would have it, just a few months ago, Heather Hofflich from UC San Diego gave a live presentation on secondary causes of osteoporosis, and I gained permission from them to show it to you. So they have monthly calls. I'll put the details of these calls in the YouTube information down there. And you can join these calls yourself if you'd like. But Heather Hofflich is part of this dynamic duo. It's her and Jeanne Woods that really get involved in the latest information on osteoporosis. This is what they focus on. You'll see them at these big trainings, whether it's the World Congress on Osteoporosis or the Santa Fe Bone Symposium. They know all the big doctors like John Bilezikian and Michael McClung or Serge Ferrari, or, they interact with these people, so they are on the kind of cutting edge of how to treat osteoporosis. So today, Heather covers, what are the secondary causes of osteoporosis. And then she goes through a lot of case studies and the testing that you should do to look for some of these secondary causes. And then she goes over a dozen questions from the audience. So this is a live training, so keep that in mind. And goes through, very thorough answers to some of these tough questions that people ask. And then finally at the end, there's a section that I put together. It's more of a deeper dive on hyperparathyroidism and hypercalciuria. So these are the two most common secondary causes of osteoporosis. So it's good to know this kind of in-depth type of look there. Now, I'm an engineer, I'm a researcher, and I'm a patient, right? I have osteoporosis, but I am not a doctor, right? Heather Hofflich is a doctor. So please enjoy the presentation. And if you have any questions, feel free to put them in the YouTube comments, and I'll do my best to answer those. So enjoy the presentation.
So today I will present on causes of osteoporosis. And once again, I'm in the Department of Endocrinology and General Medicine and worked with this bone health group since 2012. I have no disclosures. I don't work with any drug companies or anything like that. So, causes of osteoporosis. So the big discussion I want to have today is what everybody should be thinking about that actually has osteoporosis when you go to visit your primary care doctor or your endocrinologist after working that. So there is primary osteoporosis, and that is bone loss that occurs due to the normal aging process. As we all know that when we reach age 50, estrogen levels are reduced if we're not on hormone therapy, and our bone density starts to decline. Our bone density is built up, as you've learned from this group, in your 20s and 30s, and then, it kind of takes a turn and starts to go down as we age. But when we lose that estrogen in our menopause years, bone loss can occur more rapidly. And in men, as they age, we also see that when testosterone, does go down and estrogen levels as well, men, then they start to have some bone loss as well, just at a later age than women. And secondary osteoporosis is bone loss that occurs from a clinical disorder or medication, and that's what we're going to focus on. So there's been a lot of studies all along the years, when is a secondary cause found? Is it a lot? They've done all these studies over the years that found certain reasons are, and I'm going to dive into that today, about looking for a secondary cause. So we do find it in about 64% of men, 50% of women in some of the practice. So we want to think about this in all our patients when you come into our endocrinology office or primary care office. And the issues with the studies on the data is that these were referred clinics. So, but what is the cost effectiveness of running blood work or doing certain things in a general population? And that's some things that physicians, when I go to my meetings, kind of think about. When should we kind of dive in deeper with secondary causes, and when should we kind of hold and see what's going on? And as you can see, this is very old table, but I just want to say that there's a lot of reasons why people can get osteoporosis just besides aging alone. So, the first thing that I always tell when I give this talk is when you go to your doctor, whether it be your primary care or rheumatologist, endocrinologist, geriatrician, and you learn that you have osteoporosis, you want to make sure they take a really good history. So, things that your doctor wants to know is they want to know if you've had any height loss. So, greater than an inch and a half of height loss can actually be okay as you age because there's two things that can cause height loss. One can be fractures and compression fractures due to osteoporosis or kyphosis, but also you can have osteoarthritis or kyphosis that can lead where that's in the joint space, degeneration in the joint space that can lead to height loss and also. So when patients have a height loss of greater than an inch and a half and say, well, I used to be 5'4", but now I'm 5'2", then your doctor may want to get an x-ray or some imaging just to make sure it's due to osteoarthritis and not a silent compression fracture in your spine. So that's a very important piece of information that your doctor will want to know. And obviously getting measured at your visits is very important too. The second is family history. Family history is a key risk factor and is another reason that people get osteoporosis or become more at risk. So that's very important to know if anybody in your family has had a hip fracture or osteoporosis. And fracture history can help me lead to thinking about secondary causes. Any fracture over the age of 50, having rheumatoid arthritis or steroid use, being on meds, which can lead to your osteoporosis, menstrual history. So if you had menopause at age less than 45 and did not go on hormone therapy, that is a risk factor and one of the reasons that you may have had osteoporosis at an earlier rate or, more severe osteoporosis. Also, lactation, breastfeeding for very long periods of time throughout your life. I always ask patients, about that or multiple pregnancies because doing this at long lengths has been shown to induce some bone loss at that time. Alcohol is very important. That's a huge risk factor for secondary causes. Drinking alcohol more than 2 glasses a day on a daily basis can lead to bone loss and osteoporosis. Smoking directly toxic to the bones, any kind of smoking history, and soda use. There's still these studies out there that cola, not kind of these sparkling drinks that we see everyone use today, but cola, they did a study at Tufts in 2006, and there's some mixed data on this, but it was in particular with cola that there was bone loss more than 3 cans a day. In women only, there was some association. History of malabsorption. So we'll dive into some malabsorption disorders, but specifically celiac, inflammatory bowel diseases, things like Crohn's or ulcerative colitis, or people with long periods of diarrhea because they had C. diff infection. This can lead to osteoporosis through malabsorption of nutrients that are needed for the bone, such as vitamin D or other nutrients. History of bed rest, greater than 1 month. So we know that people who are mobile or wheelchair bound, lose bone at faster rates. So being on bed rest or not being able to move and walk around is a risk factor. History of eating disorders. So very low body weight and having anorexia, nervosa, or bulimia can lead to bone loss and as a secondary cause. A lot of people now are on the GLP-1s, and we're seeing a lot of rapid weight loss in people that are on Wegovy, Ozempic, Zepbound, and tirzepatide. So, we do know, and we have good data in bariatric surgery patients and in others with rapid periods of weight loss that this is a secondary cause of bone loss and can lead to osteoporosis with rapid weight loss. History of chemo and radiation therapy can cause osteoporosis. A history of kidney stones associated with something called primary hyperparathyroidism. Sometimes the stones are associated with this condition. Chronic liver disease, cirrhosis, kidney disease, chronic kidney disease, stage 3 or less or greater, stage 3 and stage 4 and 5 can cause bone loss independently of with different factors. And then exercise, people who are not out there exercising, doing their weight bearing, nutritional deficiencies, vitamin D deficiencies, calcium, people who are not getting any calcium are on very low dairy diets. There's a lot of different ways that nutrition can contribute to cause osteoporosis, and just in your diet. And also, fall history is very important. People that have Parkinson's or MS or another condition, that can lead to falls. And as we all know, falls are the reason that many people fracture. And so people with osteoporosis are at increased risk. There's many, many balance disorders out there. Vertigo can lead to falls and fractures. So it's very important when you're with your doctor, or if you have underlying medical, we need to figure these things out because these can lead to osteoporosis and ultimately fracture. So going through it again, let's go through very specific causes. So hypogonadism, when I say that term medically, I mean low testosterone levels and then, or low estrogen levels. So people with what we call amenorrhea, people who aren't getting their menstrual cycles regularly up to age 50, can have decline in bones, after age 50. If you're not on estrogen, then of course there is a rapid decline, and males can have declines with testosterone, but these can lead to osteoporosis. As I said before, age less than 45, having your menopause before that and not going on hormone therapy till age 50 can be associated with bone loss and osteoporosis. So a lot of people come into our offices and say, I have hypothyroid or thyroid disease. This is causing osteoporosis, but that's actually not true. It's specifically hyperthyroid. So, and it's not to say if you've had hyperthyroidism that that's causing bone loss, but when you remain in a hyperthyroid state for a long period of time where your TSH is suppressed. And what we mean by that is on your labs, when your TSH is very low, less than zero point 0.1. So in thyroid cancer patients, we often want to keep their TSH in a lower range. And so there have been studies that have associated that with bone loss and osteoporosis, and people that are in these that are on too much. If you have hypothyroid, but your TSH goes into the low range, you're on too much thyroid med, your doctor can obviously work with this. That can cause bone loss. So we want to keep people that have chronic hypothyroid, we want the TSH to be in a normal range. So that is what is associated with bone loss, not specifically thyroid disease in general, just to make that clear to everyone. Another big cause is a disease state called primary hyperparathyroidism. This is something that we pick up occasionally on lab work, where we have elevated parathyroid and calcium levels we'll see on blood work. And it's really just a disorder of these little four glands here in your neck where one of them, you have four glands, and it produces excess parathyroidism that actually causes some bone breakdown. And that is something that can be treated. It's a benign condition, but sometimes when it's not caught or for long periods of time, it can be associated with osteoporosis and bone loss. Vitamin D deficiency. In studies, they usually use the level of less than 12 as vitamin D deficiency. We really don't know. There's a lot of controversy over vitamin D and what the exact level is and what's associated with osteoporosis and bone loss. But we know that likely 20 and above, if your level, it's, definitely probably not associated. We at UCSD like to keep within range 30 to 50. And if your vitamin D is too high, if your level is greater than 80, be cautious because that can actually lead to bone loss. So excess vitamin D can actually cause hypercalciuria and cause problems with bone loss and osteoporosis. So it's a balance with vitamin D, and there's been a lot of changes. So you want to talk to your doctor about the right level for you, but you want to keep that in a balanced range and not too much and not too little is the key with vitamin D because you don't want to cause bone loss on either end. Cushing syndrome or having glucocorticoid excess is a very important cause. So if someone has these rare conditions where they're producing too much cortisol, it has a direct effect on the bone and could lead to osteoporosis. Diabetes, type 1 and type 2, we do know has an association with osteoporosis and bone loss, including many of the medications. So that's something that, when I have someone with diabetes in my primary care population, I'll be on it to, make sure
Are there a lot?
and be associated with that. Idiopathic hypercalciuria is something we look for that can be associated with kidney stones. That's when your body, your kidneys don't properly retain the calcium and you're excreting too much into the urine. And it's a rare condition that we can check for in the lab. Celiac disease. We know that celiac disease and inflammatory bowel disease like Crohn's and Cushing's can be associated with malabsorption, vitamin D. As I said before, eating disorders, restrictive eating, bulimic disorders can be associated, balance disorders, as I just said before, and a rare condition called acromegaly, where you produce too much growth hormone, can be associated as a cause.
Okay.
And we have many GI disease states. Once again, the malabsorptive diseases, inflammatory bowel disease, Crohn's, ulcerative colitis, bariatric surgery. And I should add it to the list. I didn't put it on today, but now I will.
Hi,
GLP-1
this is Bob Kaiserman. I was wondering if
are Oh, and GLP-1s are associated with bone loss and osteoporosis. So we do know that, we're aware of that. Hematologic conditions, bone marrow disorders, medications, which I'll get to, immobilization, transplant. We know that in the first year of having a kidney transplant, heart transplant, liver transplants, there's a lot of medicines that go into transplant surgery and put you at very high risk for osteoporosis or bone loss, with the need to do steroid treatment, especially to make sure the transplant takes. But we have an excellent program now at UCSD that one of our fellows created, so that is now an attending in our endocrine division. So there is a lot of knowledge about that. Alcohol, tobacco, as we said before, lactation,
Hello, this
pregnancies,
is Irene.
renal and liver disease, COPD, actually, chronic lung disease states have been associated, just like diabetes, and too much vitamin A can actually lead to bone loss. So COPD and diabetes, there's many disease states for different reasons and factors that we associate with bone loss and osteoporosis. So, what are some of the medications you may be on? This is what your doctor should be looking for, looking at these disease states, thinking about them, and what medications, can lead to bone loss and osteoporosis. So, one of the biggest ones that we're well aware of are steroids. So, glucocorticoids. I've seen some change. It used to be considered that if you're on 5 milligrams of prednisone for greater than 3 months, this is a risk factor. But I've even seen a lot of data now that we're lowering that to even if you're on 2.5 milligrams for greater than 3 months, this is a risk factor for osteoporosis. And then we also know that high doses over a period of a short time, for instance, greater than 30 milligrams for over a few weeks at a time, can also put you at high risk. So being on a steroid for short term, don't get me wrong, if you need it for a lung disorder, a cough or cold, a quick thing after you have your reclass therapy, it is okay. But we're talking about more chronic high dose or chronic low dose steroid therapy that can cause bone loss. Immunosuppressants for transplant patients, cyclosporines, tacrolimus, anticoagulation, being on long-term anticoagulants has been associated with bone loss. Anticonvulsants, specifically gabapentin. There's been a lot of data recently, even that being on chronic gabapentin, the reason being is that it can, you know, given that it causes sedation as a side effect as you age, it could be associated with dizziness and cause falls. Same with opioids as well, as SSRIs, Prozac, Zoloft. There's been associations. Remember, some of these are not necessarily, I should probably take out that causative statement up at the top of my slide, but associations with bone loss. PPIs I'll talk about separately. Lithium has been, chemo agents, as I said, and specific. I think I just got muted. Sorry about that. And specifically in breast cancer and androgen deprivation therapy. For women with breast cancer, there is a medicine class called aromatase inhibitors, which can lead directly to bone loss and osteoporosis. And in men with prostate cancer, it's called androgen deprivation therapy. So many of these agents, we do have a protocol for doing osteoporosis meds to help prevent and treat anything that can be. So I do think these medicines are very important, and we do have ways and protocols that we can treat. So Depo-Provera has had a black box warning and associated with bone loss, as we talked about excess thyroid medication or being on too much thyroid, Synthroid or levothyroxine or Armour thyroid or any kind of thyroid med that puts your TSH in the low normal range can lead to bone loss and osteoporosis. Diabetes meds. So I also will now add on the GLP-1s here that may be associated with osteoporosis. TZDs, we don't use as much anymore, but the SGLT2 inhibitors and also the GLP-1s, as we said, are associated with bone loss. Vitamin A excess, and then antiretroviral therapies in our HIV patients. We do see bone loss, and we need to treat because of that. And so specifically, a lot of people ask about the PPIs and fracture risk. So what we try to do is that if someone is on a PPI, definitely do not do anything. Talk to your primary care providers, your gastro, before making any changes. But we do try to switch a lot of people over to Pepcid or other, without the proton pump inhibitor therapy. I mean, omeprazole was shown to reduce fractional excretion of calcium carbonate in fasting women. There's been some associations with hip fractures and chronic PPIs, and not so Pepcid is an H2 blocker. But I guess the recommendation would be, use the lowest dose possible. As a primary care physician, as well as an endocrinologist, if you need the PPI, we do recommend it. Why? Because a lot of people need it to prevent a type of precancer called Barrett's esophagus, and you want to prevent from having reflux. And it's very important because changes in your epithelium, in the structure of your esophagus, if you're having acid, can lead over long terms to esophageal cancer and these pre-changes and dysplastic changes. So we do recommend that you are on the PPI, and we can work around you as endocrinologists, and there's treatments and things we can do. But if you don't need it or you need lower doses, definitely work with your doctor to take the lowest dose needed so that you don't have reflux. That's what would be recommended. We also do recommend a certain type of calcium if you need a calcium supplement while you are on this medicine. We recommend calcium citrate, which doesn't need an acidic environment, and possibly a higher calcium diet, because one of the things with the PPIs is that, as we said, they reduce possible calcium absorption and the fractional excretion of calcium carbonate. So those are some of the things we recommend. But at the end of the day, the PPI does outweigh any risk of osteoporosis. We can work around it. So I'm going to kind of give you guys, when I give this talk to physicians, I'm just going to show you some cases that occur in general clinics. I mean, these are from over the years, and just a reason why we do like to think about a reason for your fractures. So this was a 57-year-old female who came to me with multiple compression fractures, and she was only taking calcium and vitamin D. And this was a case that I had a long time ago, but she did have severe osteoporosis, and I had this x-ray that showed pathological fractures. And, instead of she had already been through orthopedics, and, we dug a little deeper. Well, why does she have all these fractures? And that's the point. What test should we order? What should I think about? And we did a lot of tests, and we checked for multiple myeloma, which is something else that can kind of present with a lot of fractures. But she ended up having this very high level of serum tryptase. Now, once again, this is very rare. All of you do not need to go out and think you have it, but it just shows you that, if you do have fractures or if you do have severe osteoporosis, sometimes we do think about these reasons and we find things. So this woman had a condition called systemic mastocytosis, which is a very rare condition that can cause some systemic fractures. And just to know, I've been here for 17 years, and just in my population, I've only seen this twice, and I see a lot of osteoporosis. So it's extremely rare, but when someone has a lot of fractures, we do like to press and try to find out why so we can treat them appropriately. Another case, this actually occurred in my primary care clinic. I had a 55-year-old female who felt a pop and had a compression fracture. And I noticed that one of her levels in her normal metabolic panel, her alk phos was low. And she had this high B6 level. So basically, this woman ended up having another rare disorder that may not be so rare is autosomal dominant if it's found in the adult population, but it's something called hypophosphatasia. So anyone that has this very low alk phos, we do kind of think about this and test for this in our clinics because you don't want to use bisphosphonates. But once again, I have a couple people in my practice, but this is very rare and it's a functional mutation. But we do think about other causes to, find out different ways to treat people. And then this other one is actually not quite common, but she kind of popped in to my osteoporosis clinic, a 59-year-old Caucasian woman. She had this rib fracture. We weren't sure. She had low body weight, which is a risk factor for osteoporosis. And she had very low T-scores on her DEXA scan. And she also had this iron deficiency anemia that for years she had just been sent to this hematologist and we weren't sure what's going on. So I measured her tests and I had one thought because iron deficiency anemia and things goes with a malabsorptive disorder. So what did she have? We ordered these transglutaminase antibodies and for years she had celiac disease. She was actually from Finland where it's a little bit more prevalent. And we caught her celiac disease. She's been my patient now. All of these people are still my patients, and she's doing really well. She went on a gluten-free diet. Her bone density, while it didn't improve a lot, we had to treat her, but we did get improvement and stabilization, and we have her on osteoporosis meds, but she's now doing much better, doesn't have iron deficiency anymore, and was diagnosed with celiac disease. So you can see that these conditions do pop up. And like I said, what are the most common causes? In men, low testosterone, aging, as they age, steroid use, and alcohol. This is just in a very general population in Dr. Bill Ezekian's cohort. Low estrogen, steroids, and anticonvulsants in women. And referral base, we see a lot of transplants, steroid, alcohol, aromatase inhibitors for breast cancer patients, and vitamin D deficiencies come our way. So there are a lot of secondary reasons that people may have it. A lot of people say, well, should we do blood work to look in and try to find some of these causes? And there's been a lot of studies on cost effectiveness and what should we do. And so before I get to kind of what lab work will do, I'm just going to show you one more case that is actually not quite uncommon. And this is just an example of how here at UCSD, we work really closely with our orthopedics team, and they send us some of these cases as well so that we can treat them. So this was a 57-year-old female that they were actually going to discharge, but luckily one of the orthopedists sent her to me, and she'd had this L1 compression fracture. And if you look at her DEXA, she had no conditions, no history, and her DEXA looks good. I didn't see anything that would cause a compression fracture. It has, quote, osteopenia or low bone mass. And so then I got some labs. So I took a grade history, didn't get much. And then I got these labs back. And all of a sudden I looked at the labs and I'm like, this is strange. This is for me as a physician, and her liver test is high. It kind of looks like an alcohol liver patient. And when I got further testing, because I saw her liver enzymes were up, her MCV is up, which can be a clue to a condition, this mean corpuscular volume. Her coagulation pathway was up. And then I got her abdominal ultrasound and it showed cirrhosis. And I had taken a good history, but she didn't tell me something. And actually, this is a patient who was drinking 4 to 5 drinks daily. She didn't admit this in the history. Since age 18, we got her referred to the liver clinic. She is still this was a long, long time ago, but she is doing well, alcohol-free. I have kept her off osteoporosis meds because after we treated her with the reclassed and zoledronic acid, but she stopped drinking and is doing great, and no further fractures, and has not needed osteoporosis medication in a long time. So the point is that we need to dig deeper and sometimes look at the reason why, because we can kind of stop or prevent or do different things with osteoporosis. So it's very important. If this patient hadn't been referred, we may never found the cause, and she could have kept on drinking and caused more osteoporosis and fractures. So, that's why I say that history and everything is the cause. Now, for the last slide, I'll come upon the laboratory work. So I want to say that there is some controversy. When I go to my big meetings with endocrinologists, there's a lot of controversy about what to check in the blood work, when to test, who to test. So I will say that, you know, a lot of people, you know, with osteoporosis. So in osteopenia, patients with low bone mass, osteopenia, we do not necessarily check some of these tests. Maybe we'll check a CMP, a CBC 25 vitamin D, which can rule out a lot of things that we've discussed today in this session. But when someone does have osteoporosis or an unusual fractures at a certain level, I will dig deeper, and most of our colleagues will dig deeper with you. So then we can get a 24-hour urine calcium and creatinine and sodium. Many of you who have had that know it's not the most fun test. I tell my patients, you know, the lab will give you these containers. In 24 hours, I will have you collect your urine into this container, and we will see if you're excreting too much calcium into the urine. So it's not the most fun test to have to collect over 24 hours, but it gives your doctors a lot of information. We also check phosphorus levels. I have caught some cases over the years of phosphorus deficiencies. We do know that iron infusions, certain types, can be associated transiently with low phosphorus, and we've seen that in patients. We know that PPIs, proton pump inhibitors, can do that, other things. So I do check a phosphorus. Magnesium, I actually left this on here for the talk today, but I don't do it as much anymore because it is very rare to find a magnesium deficiency in the general population. Yes, if people have diarrhea or malabsorption disorders in select populations, but in the general population, it is very rare to find just a overt magnesium deficiency. And it is not true that you need magnesium in the general population to absorb your calcium intake. Most people have very normal magnesium levels when we check it. So I don't often check that anymore. I used to check it for many years and just they come back usually normal. In atypical cases, I will check. Same with an SPEP, UPEP. We've had some debate with our hematology consults. This is a test for multiple myeloma. And, you know, there are these subtypes, MGUS, multiple monoclonal gammopathy of unknown significance. I would say that the debate is that, you know, when you do check everyone for this to assess, you will pick up some MGUS, which then has to be followed for life. What is MGUS? There's a very low rate of people with a little bit extra protein in their blood developing a lifelong multiple myeloma. And most of the hematologist notes it's about 1 to 2% if. I've caught a lot of that in my years and followed many, many patients out. You know, 17 years later, it is extremely rare. And I agree with our hematologist consult to convert. The issue is from a bone standpoint is there have been some studies that show that if you do have MGUS, this monoclonal gammopathy of unknown significance, it may be associated with an increased risk portending of fracture. And so that could give us some fracture risk data, but it is controversial. I'll leave it at that. I would recommend you speak to your physician about the pros and cons of testing for this. In men, serum testosterone, we do test for, we do find a lot of hypogonadism. I can think of my own patient. I had a patient who we found osteoporosis on his bone density and realized he was about 70 at the time, and we found hypogonadism, and then we did treat him with testosterone, and his bone density greatly improved. Now, I want to make it clear, testosterone itself is not a treatment for osteoporosis. It has never been found really to reduce the risk of fracture, but studies are ongoing. But it can greatly improve bone density. So it did help in this case, and we did some treatments with osteoporosis as well at the time because he did osteoporosis, but it was good to find that early and treat and look for a reason, but we just treated and the patient's done very nicely on the bone density. TSH, as I said, we don't want to suppress TSH less than 0.1, so we look for that. Parathyroid hormone, if someone's calcium is elevated or vitamin D is low, or kidney dysfunction, the PTH can run high. So there's a different reason called primary hyperparathyroidism, secondary, and vitamin D deficiency alone can cause the PTH to get high. So sometimes it gives us more clues into what's going on in absorption issues and different disease states. And the TTG IgA antibodies are the tests that we use for celiac that can be an initial cause to find somebody with celiac antibodies that are positive. Obviously, if someone's on a gluten-free diet already, these will not be positive. So they're not a good test. And then I reserve there is, for those, we were talked about a little bit about glucocorticoid excess, people that are secreting too much cortisol have something called Cushing's. We can, for select patients that have symptoms, do this dexamethasone suppression test. I do this only in select populations where they have had rapid weight gain or clinical features of Cushing's or glucocorticoid excess. So that is definitely not done in everyone. I talked about the serum tryptase. I don't even include that on the list, as that is something more rare as well, to check for mastocytosis, which is very rare. And then there's some other tests, before I get to that slide, that are on the list. But in general, with some of the ACE osteoporosis guidelines, and once again in 2020, these are some of the recommended tests that we recommended that I went through with everybody today. I also want to say that many patients, when you're on Medicare, we do not, and the Endocrine Society now does not recommend just general screening of vitamin D. So it is very difficult to get it covered. And population screening, is taught to physicians, is now not recommended unless you do have osteoporosis, chronic kidney disease, malabsorptive disorders, or obesity. Actually, it can be, as they do still allow it. But there's many reasons for this. And there's a lot of changes to the vitamin D guideline, but that's why many of you, if you have osteopenia or just in general health, vitamin D is not a routine screening test that Medicare will cover anymore. But if you do have osteoporosis, your doctor will likely check it to make sure that it is not low. So who do we test? I kind of already covered this slide. For a physician, should we check everybody with osteoporosis with all these labs? If you have declining bone mineral density, fracture history, there's this thought with Z-scores and associations. So really talking to your physician, clinical judgment from a physician perspective on who to test for these secondary causes. But I think, once again, the best thing that you can do with your physician is going through your history in great detail, your family history, fracture history, and just trying to hone down on a secondary cause. A lot can be gleaned in the history rather than lab tests. So I will end there, and I know I know this group well, and I'm sure there's a ton of questions. So I will put on my glasses and get to those. Absolutely. That's what we talked about. So when you have a condition where you are over-secreting cortisol chronically, that can lead to bone loss. So aromatase inhibitors, all of them, are associated with, there's been trials, the Zofast and tons of trials over the years that do show that they can lead to bone loss and fractures. So when you're on that, there is a specific protocol. Specifically, we prefer zoledronic acid, Zometa, given twice yearly for a couple reasons. And the oncology team, I know at UCSD, will use this, and they will be giving it to you if you are on this. They're excellent about the bone health in our oncology team. And the reason we prefer this is trials were done with this. And basically, it's 4 milligrams twice yearly. And the studies have shown they typically do this for 3 years while you're on this, and then, stop and assess on and off therapy. But the reason is that the trials were done with the twice yearly dosing instead of the once yearly dosing of 5 milligrams in breast cancer patients specifically. And the second reason is there's been studies in the Lancet that show that just being on Zometa with certain types of breast cancer, estrogen receptor positive breast cancers, can reduce mortality. So we prefer zoledronic acid in general because of that mortality data. Even though it was a very small risk, it's, small reduction, it's an excellent. So independently of any bone, patients with certain types of breast cancer should talk to their doctor about Zometa as zoledronic acid in general. Yeah, so I've just been diving into this, and we've been discussing this a lot at my endocrine conferences, and there's been some emails about this. So my take on this is that there's two schools of thought. So I actually test people off their calcium supplementation, and I can see a huge change when they're tested off their calcium supplementation for a few days. But I think in general, there's been a lot of recent articles about what really is the upper limit of normal. Is it 300? It changed to 250. Is it 300? So to be honest, we're just debating this ourselves in our endocrine clinic. So I would ask you to, really, I usually, before saying that someone has hypercalciuria, I always repeat because I don't want to give someone a true diagnosis without repeating that. I know it's not fun to do, but I think there's been a little bit of controversy in the area recently about who has it. It's really easy to treat. There's a treatment called hydrochlorothiazide that actually treats it and reabsorb. It's a blood pressure med, but we also use it to reabsorb the calcium. But once again, I take it cautiously and would always retest the urine at least twice before giving someone that diagnosis. And I think the numbers have changed. So I would encourage you to talk to your physician about that. Great question. So where I stand with the asthma is, the studies have been mixed over the years, but I definitely think there is some association. That being said, once again, just like the PPI story, the benefits to someone with asthma being on an inhaled steroid outweigh any risks. And like I said before, we can work around you and treat you. But I think it's important that if you do have asthma, that you remain on your inhaled steroid, because that's important and that's preventing what can be a very severe condition. So the studies are very mixed on what levels and what dosing and how, but and there's been some different data. So I think it's just important you talk with your doctor and check your bone density. No, so as we know, there is no one right type of calcium. Don't spend your money. Any type is okay. I tell this every year. We go to our big health meetings where Dr. Deb Sellmeyer from Stanford tells us this. Even the old school thought that calcium carbonate needs to definitely be taken with food is not necessarily true. So I think the point is we always say whatever calcium you want, go to the health store. We prefer if you could get it through your food or diet. Almond milk, as we've discussed, and you'll have more talks on this, is a wonderful source of calcium. 500 a day if you take a whole glass. But if you need a supplement, I always say to my patient, take a Tums, take a liquid, take a chew. It does not matter what type of calcium you take, and you do not need magnesium or vitamin K at this time. We do not have clear data. So. Well, I think we have a lot of controversies we haven't worked out, just with the calcium and vitamin D story. Do we need K? Do we need mag? Do we need an acid-based diet? Do we need high protein? Do we need low protein? How many blueberries do you need to eat to prevent osteoporosis? I think we don't know the answer to a lot of things, and I think we're working on that. And there may be some mag data and there may be some soy data, but I think we don't know right now, really, we know some things. Sorry. So, I mean, we know calcium, we know vitamin D, but we don't know a lot at the same time. So I think with our diets, a lot of people are on low dairy diets. How does that affect them? But I can tell you one thing that we are postulating. Are the osteoporosis rates higher? And I think what we did differently since I started practice in 2008, and I'm not, this is just kind of, remember, a lot of people and a lot of women in this group, and maybe even men, might have been treated with bisphosphonates when they hit osteopenia and their T-scores were -2. We used to treat everyone with these doses of bisphosphonates. And then in 2007, 8, we started to take everyone off because we realized we were leaving people on these for too long. And then we treated more when you were high risk. Well, a big study just came out in the New England Journal of Medicine in January, and it took this group of 50 to 60-year-old females and said, hey, we're going to give you a dose of IV zoledronic acid once every 5 years for 10 years. And they found that nobody lost bone mineral density. So the question I have, and I don't know the answer, is where are we now? Did we do a disservice by, we also took everyone off their HRT, rightly or wrongly so, right? So I'm not sure. I'm not sure where we'll end up. Do we have more rates of osteoporosis now because of all this? And maybe somebody in this group knows the answer. I just don't know, thinking about that, if we've processed the fact that we've changed a lot of the ways that we've done prevention. And as you guys know, Dr. Woods, part of our team, is really working on that. Let's get prevention back in the discussion. I feel the same way. Should 50 to 60-year-olds have a dose of IV bisphosphonates every 5 years? Should you go on hormone therapy? Should you go on bisphosphonates in your 50s? We're just starting to talk about this. This is coming into play. So I think we have a lot, to come on this topic. So great question that we're starting to process. So, right, the black box warning was removed in 2021. And so I think just talk to your individual physician about going longer. There's many reasons that you could go back on a bone builder such as Tymlos now that the black box warning is removed. And so I think talking with your local physician, do we treat more than 2 years or go on and off therapy? Yes, that is the wave of the future. And we do use it long term for certain disease conditions now. I have a patient that's now been on it over 2 years because she has significant CK, chronic kidney disease with low bone turnover. And, it's also up to insurance. So that's always a limiting factor for us. But yes, I would encourage people, you can talk to your doctors because times have changed. So DEXA scans are still the gold standard. And that's what we use. That's what treatment algorithms are based on. But you are correct. I mean, that doesn't necessarily take into bone quality. That's only two areas of the bone. And so, there was a time where people were getting CT scans and more volumetric data. We don't encourage you to just get a CT for that reason. But when people have CT scans, there are a lot of ways out there, and Medicare does approve it, that you can actually have your bone go through a stress test through CT scans. And so if you've already had one done, so you can talk to your doctor about that. We also have trabecular bone score on all the DEXAs done at UCSD, not necessarily outside of the San Diego. We do look into it's another measure. It's a grayscale image that helps us a little bit more look at the quality of the bone. And that's been helpful, I would say, in certain circumstances, but not all. So I do encourage you talking to your physicians individually about that. But right now, I would still say there are a lot of things coming. DEXA is still the gold standard in treatment decisions. Correct. So there have been lots of studies over the years saying that even if your bone mineral density doesn't change, let's say you start a med and you really stay in the same range, even then you get a fracture reduction, right? So what are the endpoints? The endpoint in these studies was always fracture reduction. Well, now that's changing. So more to come on this topic, and there'll be other speakers that can answer that question that you'll have in your curriculum. But in the sake of time, basically, they will probably be changing to look at hip bone mineral density as an endpoint in a lot of studies. And then, there are a lot of data out there that's saying treating to a lower T score, correct, is better for fracture reduction. We know that's always better, but more to come about certain treat to target. But there's been a lot of controversy with this. So I encourage you to keep your ears open as you hear. There's been a lot of different ways to do it, but a lot more is coming out about that. Right. So magnesium, is used for a lot of clinical disorders. I've seen it used for sleep and for leg cramps and different things. I just want people to understand that you don't need it for necessarily for your bones, as most people are not deficient. I mean, your doctor, as I said, I don't typically check, but you can check that. So, of course, and there may be data. I mean, there are people working on this. So keep your ears open about it. But I just want to make it clear that there's this myth for some reason that you need it to absorb your calcium, and that's just not true. It is true in the inpatient setting. Don't get me wrong. When people are very low in mag, they need magnesium in order to absorb their calcium. But in the outpatient general population I'm speaking about, you do not need mag to absorb your calcium. And it's okay to, I mean, it's safe. I always say with supplements at your own risk, but I just want everyone to be clear it's not a necessity at this time. It may be soon though. I keep that door open. There's very good papers out there about that. We're waiting for the data. How's that? Yeah, so bone markers are very controversial when you dive into the bigger world of osteoporosis. You'll see when I go to conferences, half the teams check it and half the teams don't. There is a clear point when I will use bone markers, and that is when I'm transitioning someone off denosumab or Prolia. It's very important that we check a C-telo peptide level. Baseline, these are not diagnostic indicators necessarily. There's been some issues with fasting, time of day to get it, variability, but there are a big group proponents for it. There's some that don't, against it still when you go into the bone world. So I would consult with your doctor. Where P1NP specifically as a marker of formation can come into play is that when you're going, and this is not with romosozumab and Evenity because levels dip, but with the abaloparatide, the Tymlos, or the teriparatide, the Forteo, it can be used pre-treatment, and then you would see a rise after 1 to 2 months to show that it's working. So some people do use that bone marker to demonstrate that. And then some people do use the C-telopeptide as kind of a marker that your bone turnover is suppressed when you're on anti-resorptives and different medications. So it's called a C-telopeptide. So they can be very useful. Every clinician uses them a little differently, and they are, I would just leave them that they're controversial and not everyone is using them. So hyponatremia, there can be, and yes, that is a good point. Sodium levels are important. High sodium levels have been associated with bone loss, but with low sodium levels, they can be in the sense of what is the cause. So I would first dig into the cause of low sodium and associations, but there is data. Dr. Elizabeth Barrett-Connor, all these years, there's been data with iron and sodium and different things. So I think it is important in the picture and more to come about those kind of levels. Right, so I'll make this clear for everyone, a decision to go on a bone builder medicine. So if you're gonna go on either romosozumab, which is Evenity, abaloparatide, which is Tymlos, or teriparatide, which is Forteo, these are bone building medications. All three of these need to be followed up with an anti-resorptive. So that means you either need to follow it with a bisphosphonate, which comes in an oral form or an IV form, as we discussed today, or denosumab or Prolia. You have to do something, or else over 18 months, you will lose everything you got. So I never put someone on one of these therapies without confirmation that we are going to then go to something to help maintain the bone density, or else you'll just lose what you got, and it's not worth going on any one or of these medicines. So most of my anabolic patients, in a younger age group, I tend to like using the bisphosphonate group because then we can pivot back to something else in the future. Because Prolia, as we all know, and you've learned in this group, once you go on it, you're on it for a long time, and it's hard to pivot off, because to go on Prolia is also a decision to go on a bisphosphonate if you're going to go off of it. So for older people that are on Prolia, you may be on this for the rest of your life. But for other people, if you need to stop at any time, you have to go on a bisphosphonate to be able to go off of it. So sort of all roads in a way lead to a bisphosphonate, depending on your age. Obviously, in older patients, we can keep you on Prolia for longer, meaning that if you're above, we have 10 years of data with Prolia, and we're even extending people out longer, but we'll never have more than 10 years of data with that necessarily. We'll have real world data, but in a clinical trial. Sorry. I have never seen a patient or used that scan. I know about it, but at this time I use the DEXA scan. So more to come on the REM scanning, but at this time DEXA scan is standard of care.
Great.
And there's other ways that I can get volumetric information with the trabecular bone score and with certain CT and other X-ray imaging. So I get a lot through that.
All right, so let's talk about the calcium-related diseases that can lead to osteoporosis. All right, so back to our chart here. Here's Mike sitting at 9.7. Looks like it might be shifted a little bit more, and life is good, right? My parathyroid glands are working just fine. But what happens if one of those glands decides to swell up or overgrow? Right? And what happens is the cells, for whatever reasons, just say, hey, I'm going to start multiplying, right? It's kind of like a cancer. It can be cancerous, but typically they're not cancerous. It just grows too big. I guess they call it an adenoma. And what I'm going to show you here is a quick, let me just click here. And you can see that parathyroid gland, one of the glands, just starts growing. And the result of that is your calcium set point, that kind of happy point, gets shifted upwards. And in this example, you can see you have high calcium, your PTH will be high on your blood test. It's actually pretty easy to see this condition. And this is called hypercalcemic hyperparathyroidism. So if your calcium is high and your parathyroid hormone is high, you could very well have this problem. This is a very prevalent secondary cause of osteoporosis. Okay, so now let's say, all right, my happy point's at 8.9 or 9.0. And everything is working great, but you know what? Over the years, all of a sudden you see your calcium kind of shifting up. So in this example, the parathyroid gland is growing. It's putting out too much PTH for your body. It's forcing that happy spot all the way up here at the top range, but it's not out of range. This is called normal calcemic hyperparathyroidism. So your PTH will be high, right? It'll be out of range, but your calcium is still in range. So this can happen. It's not as prevalent as the first example, but it can happen. So something else to be aware of. So how do we spot this, right? What are the numbers? Let's put some numbers to this. Well, this is a study of 16,000 patients that underwent parathyroidectomies. So that, cut out the parathyroid gland, get the one gland out, the other three will be just fine. And these were the conditions for these patients. And you can see on the left-hand side there, the calcium, the kind of most prevalent number, the most popular number was around 10.7, 10.8, where these people said, hey, you've got a problem here, let's take out that parathyroid gland. So if your numbers are like at 11 or 12 or 13 or God forbid 14 or 15, I've heard of numbers that high, though they are extremely rare. You need to get that looked at, right? More than likely you have a parathyroid gland that's really out of control at that point. But however, that said, you can see in that green box, this is kind of the normal range on most blood tests. And again, it was, while your calcium was still normal, the parathyroid was high, and that's bad for bones, and they actually did surgery to remove the parathyroid gland. Now, if we look at the right-hand side, again, here's the people that underwent surgery. The PTH, it's around 90 to 95 range. That was the most popular for this hyperparathyroidism. But numbers can be much higher than that, and it's like, wait, this is a pretty good indication. And even if your, let's say an example is your calcium's at 11 or 11.5. Let's really throw it over there. But your parathyroid hormone is at 55. And hey, that's within range. What's going on here? Well, it still could be that your parathyroid gland is swollen because it's too high for what your calcium is, right? So they will operate on those people and pull that out, and your calcium drops back down in the normal range, okay? So this does happen. However, there can be other reasons for high calcium. There can be quite a few other reasons, but I wanted to show this one example, and Dr. Delazekian, I put the link again at the bottom. You can watch him describe this. And unfortunately, he didn't put a whole lot of references, so I couldn't really look up the studies, so I'm a little bit hesitant to show this, but it's something we should all know about, right? Which is if your calcium is high, so this on the chart on the left-hand side, it says number of high calcium patients. So in this test population, they took, hey, you have high calcium, come over here, right? In 111 of those patients, 54% of those patients had surgically confirmed hyperparathyroid. So they had a gland that was too big, and all the P's on the right-hand side are the surgeries that happen to, fix the problem, so to speak. And you can see if you kind of tear into this chart, you can see that there were some that had normal PTH, yet had high calcium that were operated on and, cured the problem. Okay, that said, there's another group here, and it's a pretty sizable group, where it's some sort of malignancy has caused this high calcium. And they show up much differently. If we look on the right-hand side, so the T here, the T's down here, the calcium is high, right? Starting at, say, 10.5, all the way up to 16, right? But the PTH is normal. The PTH is, even low. That could be caused by some sort of malignancy, some sort of cancer in your body, perhaps. I'm not saying you have cancer. Geez, that's why I hate even presenting this, but it's something you need to get looked into. But that said, it could just be that your vitamin D levels are way too high. Because remember, that will increase your calcium, your blood calcium, and your PTH will be low. So, that's another thing that kind of looks like this. And there can be other various reasons. So again, don't panic here by any means, but if you have high calcium, especially if it's in the 11s, you really need to take a look at that and see what the heck's going on. Okay. Hypercalciuria. This is my favorite one. Not really. And a lot of this information, actually all this information, comes from Dr. Frederick Coe. He's a fantastic guy. The guy's 87 years old. He's sharp as a tack. As a matter of fact, I just had a call with him for my condition, and he's helping me through. I'm one of those special cases with hypercalciuria. But your kidneys will, if you look at the left-hand side, your kidneys will filter your blood all day long, all the time, right? And it filters about 10 grams, right? 10,000 milligrams of calcium gets filtered in any one day through your kidneys. And the kidneys will filter it, and then it shoves it back into the bloodstream. But it doesn't get it all, right? You're going to have some that comes out. It's not 100% efficient. And typically, you might lose, say, 100 milligrams a day, right? If everything's working well. However, if you're losing numbers, and the numbers are down here, if you're a woman, about 250 milligrams a day, you're considered to have hypercalciuria, right? If you're male, it's 300 milligrams per day. And this is not a good thing for building bones. And let me show you that on the right-hand side here. So Dr. Coe has gone through and plotted a whole bunch of different patients. And yes, it's a pretty wide scatter plot, but what he's done is he's put some lines here as the average for these two groups. And the first group is for normals, right? The normals being the people that don't pee out over 250 milligrams per day. And what they found was, if you took less than, if you look at the chart here at the bottom, if you took less than about 800 milligrams per day of calcium, you were losing more calcium in your urine than you were absorbing through your intestines. And they can measure this. It's pretty wild how they measure how much calcium is coming out in your stool and how much is coming out in your urine and how much you're taking in your diet to get these numbers. But you can see for the average normal person, if you're not taking 800 milligrams, you're more than likely losing bone. And now if we look at the hypercalciurics, right, the red line there, man, it's really difficult to get to a point where you're not going to be losing bone. This is why you have to fix this, right? The gut can only absorb so much calcium in one day, and if you're peeing out more than you can absorb in, you're going to lose bone, period. So you've got to get this fixed, right? Medications aren't going to, or osteoporosis medications, right? All of the fancy ones, pick one. They're not going to work very well at all if you can't get this fixed. So how do you fix it, right? Okay, so I've had quite a bit of personal experience in this space here. And this chart was really good, and I'm working again with Dr. Coe, and this is Dr. Coe's chart. Unfortunately, he changed the colors here on me, but if you're a normal, right? If you're one of them, and let's say you're taking 4,600 milligrams per day of sodium, which by the way is like the average for the American diet, and it's really easy to get to 4,600 if you start reading labels and you like bread and pastas and such. So barbecue sauce, just about anything. Anyway, so let's say you're at 4,600. All right, well then your urine might creep up to, closer to 200 milligrams per day. But if you can drop that down to say below 2,000, you can, cut that down to say 100. All right, so here's a way for you to control your urine calcium. Now, if you're hypercalciuric, it's even a greater effect, right? If you go from 4,600 and let's say you're peeing out 400 milligrams per day, well, if you can bring that down to say 2,000, you might just cure your own hypercalciuria just from lowering sodium. And the reason why this happens is it has to do with how the kidney reclaims sodium. So let's say you're not taking very much sodium at all. All right, what will happen is, by the way, sodium is absorbed very well into your bloodstream. It's like 90 9% or a lot of it comes in. And your kidney will say, okay, well, Mike's not taking very much sodium. I need to reclaim more sodium. Well, when the kidney reclaims sodium, it can bring calcium with it. If you have too much sodium, your kidney says, hey, I'm going to flush out the sodium. I've got too much sodium. The calcium will go with it. So that's how this works. It's a pretty simple fix for a lot of people. So your doctor, if you're at this point at a nephrologist, they'll say, hey, first thing you gotta do is cut your sodium way down. And they can see it on your urine test. So if you get a 24-hour urine, they'll look at the sodium. If you're eating a bunch of sodium, they're gonna catch you. So make sure you regulate your sodium if you want this to work. Okay. Looking at your blood sodium levels, again, it's very much like calcium. It's very well controlled. It's not going to move very much at all. And by the way, it's really hard to get too little sodium in your diet. It can happen, but it's very difficult for that to happen. All right, so let's say you reduce your sodium, like I did, and bare minimum, and your urine calcium is too high. Well, the next step is going to be medication. And it's their special class of medications called thiazides or thiazide-like diuretics. And these work, again, with the kidneys. It has to do with the absorption of sodium and turning off these transporters so calcium comes in and sodium goes out and such like that. But that's kind of that next step, and there's various flavors at various doses of these medications, and I think I've been on all of them. So that's kind of that next step. But again, this is something you want to fix. You really have to fix for even your osteoporosis medications to work well.